Well, good day, everybody. My name's Martin Kiernan. It's a great pleasure to be speaking to you from the UK. And joining me today is Professor Didier Pité. Didier is in Geneva, where he is an infectious disease expert and director of the Infection Control Program, the WHO Collaborating Centre on Patient Safety. He's also the external lead of the WHO Global Patient Safety Challenge Clean Care is Safer Care, and also the African Partnerships for Patient Safety. Today, Didier's focus is going to be on environmental hygiene, and we've been celebrating Clean Hospitals Day 2021 with a digital day that's run for most of the day. So hopefully Didier's throat has recovered because he's been speaking most of it, and he's now going to be addressing us on the subject of why environmental hygiene is more important than ever. So welcome, Didier, as ever.
Thank you very much, Martin. It's a pleasure to be here with you in the context of this Weber teleclass and to address why environmental hygiene is more important than ever on these precise Clean Hospitals Days 2021. So if I go to my second slide, which is the outline of my talk, you see the different topics that I will be addressing today, from reviewing the importance of environmental hygiene and patient safety, to Clean Hospitals project activities, to reviewing some of the work that has been conducted, a systematic review, the development of a framework, as well as discussing a little bit the cost and value of investing in environmental hygiene, to end up with looking at some perspectives of clean hospitals. Let's move to slide number 3. Review of the importance of environmental hygiene in patient safety. Slide number 4. Slide number 4 reviews simply the burden of healthcare-associated infections in the world, as you know, and that's a very important matter. Well, we know that we are all living in a pandemic today. We have been through a pandemic, but the silent pandemic that results from healthcare-associated infections for many, many years is something that I like to repeat. We are in this silent pandemic for quite a bit. At least, as you know, 500,000 patients are infected each day in hospitals, only explaining for what is this silent pandemic. And among all those patients getting infected after 1 year, there will be around 16 million deaths every year in the world just because of healthcare-associated infections. Importantly, no healthcare system in the world has solved this problem, and more than 50% of those infections are caused by contaminated hands. Now let's move to the next slide, slide number 5, review with you the COVID-19. The COVID-19 situations have sensitized the whole world to contact transmission. So we revisited the fact that hands and environment are so important. Hands are a hypermobile prolongation of the environment, if you like. The good news are that environmental hygiene and infection prevention and control awareness has probably never been so important, and as John Arthur liked to say, never waste a pandemic to actually discuss and address the issues of infection prevention and control, and in particular today of environmental hygiene in healthcare. The next slide, slide number 6, revisit for you hand hygiene, and in particular alcohol-based hand rub as standard of care that have saved hundreds of millions of lives, saved billions of dollars, became a global movement and standard, and has been officially adopted in almost every country in the world, covering today of this worldwide campaign of 98% of the world population. Slide number 7. What is the WHO multimodal hand hygiene improvement strategy? You know about it. We spoke about it many times, including in this Weber teleclass. It's based on WHO guideline on hand hygiene in healthcare that we edited in 2009, And it is made up 5 core elements to improve hand hygiene in healthcare settings. You remember these elements: system change, training and education, evaluation and feedback, reminders in the workplace, and institutional safety climate. Let's move to slide number 8. Where are we today? Worldwide hand hygiene implementation level monitored through the hand hygiene self-assessment framework. The paper is in press in the Lancet Infectious Disease and based on more than 6,000 healthcare institutions all around the world. Here are the average, and in this case, median level of system change, training and education, evaluation and feedback, reminders in the workplace, and institutional safety climate, as assessed during the survey that was conducted in 2019, analyzed in 2020, and will be published, as I just said, this year. This is important. This is to say that we can monitor hand hygiene progress all over the world, and that there is still a large room for improvement. The next slide, slide number 9, is here to remind you about the continued use of the WHO hand hygiene self-assessment framework that has been translated in many different languages and is linked to action at the point of care to improve hand hygiene. The next slide, slide number 10, reminds you about the 5th of May, which is this WHO Day on Hand Hygiene for healthcare institutions all over the world, and that is a reality every year since 2009. This is one of the main posters of this year. Slide number 11, see the poster and the advice to IPC practitioners: be a champion and mentor for clean hands at the point of care. Slide number 12, for facility managers, ensure hand hygiene supplies are available at every point of care. Slide number 13, for policymakers, invest now to ensure hand hygiene for all. Slide number 14, patients and families, help us to help you. Please clean your hands. And slide number 15, about vaccinators, clean your hands with every vaccine. Now, importantly, slide number 16, we developed actually posters for everyone. We actually mobilize the population all over the place. Slide number 17, slide number 18, we produced posters version with masks, without masks. Slide number 17 and 18. Slide number 19 now. What did we learn? The last 25 years have shown that global change is possible for hand hygiene. It is given to us, those 25 years have given to us a blueprint for how to replicate the model for environmental hygiene, using multimodal strategy, using the concept of adapt to adopt, and using self-assessment framework and associated tools. Let's move to slide number 20, which highlight the second item of my outline, which is the Clean Hospitals project, looking at project activities. Slide number 21. Well, today's challenge is actually to repeating this global movement that you have seen for clean hands for environmental hygiene. This is so important. Next slide, slide number 22. Let's remember about the scope of healthcare environmental hygiene. First, there are technical components. Among technical components are water management, surface cleaning and disinfection, sterilization and device reprocessing, waste management, air management, and land use issues. Next slide, slide number 23. In the scope is also human component. Human components are very important. What about the workflow? What about career development of cleaners? What about training? What about monitoring? What about cost and value of healthcare environmental hygiene? These are very key components that we need to consider when we want to analyze, understand, and actually act at improving healthcare environmental hygiene. Slide number 24. The role of the environment in patient safety. A quick review of the evidence. Slide number 25. How long, the question is, how long do nosocomial pathogens persist on inanimate surfaces? I take here a table from the paper by Kramer and colleagues in BMC, Infectious Disease in 2006. I will not review all bacteria and microorganisms on this slide, but as you see, if you take the first line with many different references, Acinetobacter can stay in the environment between 3 days and 5 months, which is a very, very long time. If you take E. coli, between 1.5 hours and 16 months, according to many references. If you take Enterococci, including VRE or vancomycin-sensitive Enterococci, it could be demonstrated to stay between 5 days and 4 months, and so on, and so on, and so on. In other words, nosocomial pathogens can stay in the inanimate environment and surfaces for quite a long time, telling you the importance of cleaning the environment. Next slide is slide number 26. I like this slide. This slide is taken from the paper by Stephanie Dancer in Clinical Microbiological Review in 2014 that shows the relationship between environmental bioburden and hospital-acquired infections. On the horizontal axis, you see the total number of so-called hygiene failures. So failure to clean the environment, failure to consider the environment as important, failure to do your job nicely, as well as on the vertical axis, the number of ICU-acquired infections. And as you see, the more the number of total hygiene failures, the more the number of hospital-acquired infections. So there is definitely a relationship between the poor or the bad or the insufficient or the suboptimal cleaning of the environment and the number of ICU-acquired infections. Next slide, slide number 27, shows to you the risk of acquisition from prior room occupants by microorganisms. Very importantly, if you go in a room where it has been before occupied by another person that was colonized or infected with one of those pathogens, your risk of getting the infection is higher. And the risk is expressed on actually the figure on the right-hand side, expressing the odds ratio for several pathogens, whether it would be MRSA, VRE, E. coli, Pseudomonas, VRE again, C. diff, MRSA again, and Acinetobacter, and an average figure. And this is from a paper by Mitchell and colleagues published in Journal of Hospital Infections in 2015, and I don't think a better paper has been published since then. So as you can see, the odds ratio is around 2 as an average. So your chance of getting the same microorganism or the microorganism of the same family of the prior occupant in the room is as high as 2-fold increased. Next slide is slide number 28. We tried within the Clean Hospitals project to identify the needs. There are needs for environmental hygiene. The healthcare environment remains a major gap in infection prevention and control. We need to address silos and fragmentation in the field that are so important. Clean Hospitals' official launch was at Interclean in Amsterdam in 2018, and we continue to build up and work on this project. Slide number 29. What is Clean Hospitals? Clean Hospitals is a coalition of international stakeholders who work explicitly to actually promote and support healthcare environmental hygiene through research, publications, participations in conference and events like the Weber teleclass tonight, education and training, and specialized working groups. For those interested, you can access the website cleanhospitals.com. Next slide, slide number 30. Clean Hospitals brought together academia and industry to champion the science, the best practices, and evidence-based solutions. To create a network where project members can exchange and collaborate. To create a platform from which to bring healthcare environmental hygiene into the spotlight. And those elements are extremely important to me. Next slide, slide number 31. What is our mission? Our mission is to reduce the burden of healthcare-associated infections all around the world by improving environmental hygiene practices. Looks simple, but certainly a very important mission. Next slide, slide number 32 is summarizing for you our numbers in 2020. The year was very busy. The year was very busy, a very busy year for Clean Hospitals, despite the COVID-19 situation in which every one of us had to work and invest in. We published 9 peer-reviewed publications. We had other publications like white papers. We gave conferences in person. We gave conference remotely. We participated to 3 different teleclasses and webinars. The Clean Hospitals Day teleclass last year was very successful with more than 20,000 live attendees and more than 77,000 on-demand attendees. The teleclass on COVID and fake news was attended by almost 40,000 people. We had 1 Global Clean Hospitals Day. We wrote 1 book chapter. We had more than hundreds citations and more than over 45 updates and short publications with new items on the website. So a very active year. Slide number 33 is summarizing for you Clean Hospitals publications in the last 2 years. This is summarized on slide number 33. You will have the slide so you can access the slide very easily. On slide number 34, you see more publications from the Clean Hospitals group in the last 2 years, as well as on the slide number 35, where you see also publication from this group in the last 2 years. So a very, very, very active group, as you can see. Let's move now to slide number 36. Clean Hospitals Day last year was specifically focused on COVID-19. We developed videos. We had the Weber teleclass that I just referred to. We provided webinars. We had industry involvement, and we had social media activities. For those interested, you can access the cleanhospitals.com, Clean Hospitals Days. For today's activities, I will come back on. Next slide is slide number 37. Today is Clean Hospitals Day. Here is the program. I gave a keynote lecture in an 8,000 participant meeting at Index actually in Geneva. We had the first Clean Hospitals Digital Day, and those of you participating in the Weber teleclass were invited to participate for free to these activities. The activities end up 1 hour ago, but you can probably still register for the next Clean Hospitals Digital Day. I will come back on you. There is this Weber teleclass now, and I also delivered a Weber teleclass in French that you can find available on the YouTube channel of the Clean Hospitals. Please, again, reach the cleanhospitals.com website for more information. Next slide, slide number 38. To summarize for you what is Index, it's the largest global meeting place for the non-women's market that are certainly very interested in infection prevention and control, where I give a keynote, and then there's an innovation consortium that I moderated, and for those interested, you can access these through the website that is indicated on the slide. Next slide, slide number 39, shows to you the first, very first Clean Hospitals Digital Day that was organized today with an opening address and then a first session, a break, a second session, a break again, a session given organized by XCT, a large session of 1 hour organized by Saraya, and then a panel discussion that was moderated by the moderator of tonight, Weber Teleclass, Martin, and on COVID and healthcare environment, hygiene perspective for the future. On the next slide, in details, you see the program that we had for these Clean Hospitals Digital Days. For those who want to actually access the material, if you are registered, the material is available between now and the end of the year, up to the 31st of December, and you will find lectures in the cleaning and disinfection in healthcare settings by Oyan Asadian, David Colfie, lectures in the virucidal efficacy by Ellie Wishart, then the session by SCT, the session by Saraya, and the panel discussion moderated by Martin Kilman on the COVID and healthcare environmental hygiene perspective for the future. The next slide, slide 31, to give you the idea of the Saraya Symposium that was addressing the topic hand hygiene challenges in the community and healthcare settings during COVID-19, alcohol-based hand rub as a game changer, where we revisited the use and perception of alcohol-based hand rubs in the community and healthcare settings by Pierre Parnet. Are alcohol-based hand rubs efficacious against COVID-19? How about quality control and cost effectiveness by Fernando Bellissimo Rodriguez? Local production of alcohol-based hand rub, a perfect example, ready for prime time in Uganda by Hiroki Saito from Japan. And for those interested, again, you can access the Clean Hospitals website and register, and these material will be available up to the end of the year. What about the second Clean Hospitals Digital Day? I encourage all of you to register for the 7th of December. You can have a look here at the preliminary program. We will be actually revisiting the REACH study, lessons learned from the REACH study by the first author of the paper, the REACH Cleaning Pendle Methods and Results by Brett Mitchell from Australia. Then evaluating bioburden of frequently touched surfaces using ATP methods by Greg Wickley. Then we'll have a live discussion. Then the second session will be actually to air treatment and purification, a systematic review of the evidence by Azan Musavi from the US. Then we'll discuss the effectiveness of air cleaners for removal of virus-containing respiratory droplets. Then there will be a live discussion and a panel discussion again, how to promote sustainable innovation in the field of healthcare environmental hygiene. Next slide is slide number 43. Importantly, in these Clean Hospitals Digital Days, we want to support the very low and low-income country with this partnership that we have with the Weber Teleclass and with Paul Weber in particular. We offer access for free with the support of professionals from very low and low-income country to participate to the Clean Hospitals Digital Day. For this, we are asking for funding from companies of 2,000 euros that will actually cover for more than 100 participants to the Digital Day for the entire year, actually. Special conditions will be formulated for middle low-income country, and the current database includes more than 100,000 healthcare providers and others from all countries around the world. Next slide shows to you, slide number 44, the main sponsor of the first Clean Hospitals Digital Days, and I would like to thank them, B. Brown, XCT, and Saraya, for being so supportive of this very first Clean Hospitals Digital Day. Slide number 45, to tell you that on these Clean Hospitals Days, we have launched posters that can be used all the year long. You can adapt them to local languages and needs. You can encourage discussions and environmental services staff empowerment. I show you on slide 46 some of those slides. One about risk zones in healthcare facilities, another about the risk zone when the risk increases, the frequency of cleaning must, of course, rise. Next slide, 47, transmission in healthcare, this triangle between host, pathogen, and infection. Slide number 48, addressing the sinner cycle that we will develop in order to help educating cleaners around the techniques for healthcare environmental cleaning. Slide number 49. To move to the next outline I wanted to address with you today in this teleclass is to review the results of a systematic review of intervention in the healthcare environment, including their effect on key pathogens. A systematic review that we have conducted that is still unpublished, and I will show you now preliminary results. Now, the question is, are cleaner hospitals really safer hospitals? And why perform a systematic review on this question? Well, it's obvious. Contaminated hands can cause at least 50% of healthcare-associated infections. But relatively little is known about the remaining proportion of infections. There are few high-quality studies that link environmental health care hygiene interventions to a reduction of either patient colonization or healthcare-associated infections. Environmental hygiene is an often neglected field, and healthcare facilities tend not to invest sufficiently in environmental hygiene. So there are many reasons for this. One is the lack of literature into the role that environmental hygiene can play in patient safety. Slide number 52. Show and summarize for you our design and methods. Our primary outcome was a comparison of the measure of patient colonization or healthcare-associated infection compared to a baseline. Secondary outcome, reduction in environmental bioburden. We use PubMed and Web of Science databases. We look at papers published until December 2019 because we wanted to exclude the COVID outbreak time period. Exclusion criteria included in vitro studies, different outcomes, hand hygiene interventions conducted in parallel that will reduce infections too much, outbreak situation, and complete structural rebuilding of institutions. Slide number 53 show you the PRISMA flow chart. We started with a lot of studies, and we ended up, as you can see, in 26 studies, including qualitative synthesis that we could do. Next slide, slide number 54, 54 showed you the overall results. Our primary outcome, most interventions showed a reduction in colonization or infections. 88% of studies showed a decrease in colonization or infections for at least one of the organisms tested. 58% of studies showed a significant decrease in colonization or infection for all organisms tested. 42% of the study were of good quality according to the scoring system that we developed, and 81% of study interventions were recommended by the authors. Studies often were not powered adequately to measure significant reduction. Speaking of the secondary outcome, all studies that analyzed bioburden showed a reduction in bioburden. Next slide showed you the information extracted from studies. That's pretty normal, but you can see, I won't detail this slide, but you see what we have extracted from the study. Next slide, slide number 56. What about the quality of the study? Overall, high-quality studies are rare, and were rare in this systematic study. Five only, should I say, were randomized controlled trials. 6 had really a true control. It's difficult to adapt the score for judging quality. There is a frequent lack of controls, use of proxy controls, and studies that were often not designed to assess colonization or infection as primary outcome. Our scoring system assessed 5 elements: study design, sample size, control, confounders, and conflict of interest or reporting issues. And we gave 0 to 4 points to each of the 5 elements for a maximum of 20 points, and graded the study in grade A to D according to the scoring. The score, of course, is not intended for any purpose behind its use in this review, and maybe will be used in other review in the future. Next slide. The success of the interventions partly depended on the microbes actually that were studied and how successfully specific microorganisms are spread through the environment. Most commonly studied microorganisms were, out of 26 studies, 13 observed the impact of the intervention on MRSA or Staph aureus, 17 on C. diff, and 12 on VRE. So very important. Next slide shows you a deeper dive into the interventions by microorganisms that we conducted, results of studies with a grade A or B. So we took only the 2 best category of studies, those that had a control and that looked at either Staph aureus, C. diff, or VRE, and that were organized by individual experiments per organism. And there was only a total of 5 studies. Next slide showed to you the 5 included studies. The study by Ray et al., published in 17, the study of John Boyce et al., published in 17, the study by Mitchell et al., published in 19, the study of Anderson et al. In 17, and the one by Mark Wilcox et al. In 2003. And you see, first line, that the first study was a study that was on mostly human factors. Study type you see on the right-hand column, the number study by Boyce on chemical, and the 3 studies highlighted in green were looking at bundles, very importantly. Next slide, 60, showed you the intervention by interventions on C. diff, and you see that each of the interventions has been listed on the 3rd column as bundle, hypochlorite, liquid hydrogen peroxide, training, monitoring, and feedback, and UV on the impact on C. diff, and you can see the impact that is listed on the right-hand side column. Next slide, you see the same approach used actually for Staph aureus or MRSA, based here on a total of 3 studies, as you can see, looking at UV, bleach, bundle, or liquid hydrogen peroxide, and you see the reduction on the right-hand side column of your slide. Next slide, slide 62, intervention on VRE that are based in this case on 3 studies, and again on VRE based on the intervention that were bundle, liquid hydrogen peroxide, UV, bleach, or bundle again. And as you can see, reduction that are listed on the right-hand side column. Next slide, slide number 63. Overall results of high-quality studies on common microorganisms showed a high heterogeneity, showed that each intervention was only tested once per microorganism, that of course reduced the generalizability of our studies and cannot reform a meta-analysis. So we couldn't do a meta-analysis. Next slide, slide number 64. The main messages are the healthcare environment is really important for patient safety. We need more and better research, definitively. But we do not need to wait for those studies to bring us results to start making healthcare environmental hygiene a priority for patient safety from now. And this is, I think, very, very important to keep it in mind. Let's move to the next slide, slide number 65, which is again coming back to my outline. And now I will be addressing the development of a new framework and scoring system and results of a global Sentinel survey. Next slide, 66. Where do we go? Well, we go, and that's why I started this conference today by showing you results about the hand hygiene self-assessment framework and the last global survey that we conducted for WHO in 2019. Because remember, we used this hand hygiene self-assessment framework actually since 2009, conducted a global worldwide survey in 2011, another one in 2015, and a third one in 2019 to assess the progress made in hand hygiene all over the world. We want to do exactly the same thing with the concept of clean hospitals. And we are developing currently the healthcare environmental hygiene self-assessment framework. It will be a multimodal framework, probably based on the same type of approach. Let me remind you that the 5 modes for the hand hygiene self-assessment framework were system change, training and education, monitoring and feedback, workplace remembers, and cultural safety climate. Next slide, 67. The idea is for institutions to improve, not to meet a predefined level, but to move the same way those institutions moved in the hand hygiene self-assessment framework from a, let's say, inadequate to basic, basic to intermediate, and intermediate to advanced level for hand hygiene. We want to promote the same strategy for the healthcare environmental hygiene self-assessment framework. Let's move to slide number 68. And let me tell you where we are today in this development of a healthcare environmental hygiene self-assessment framework. Let's speak about methods. We sent out a survey in 3 rounds starting on April 16, 2020. So we are talking about 18 months before. In the middle of COVID, we started the survey that was ready to go for a few months. Importantly, the initial round aimed for 2 hospitals per country and included 175 countries from our database of over 18,000 hospitals around the world. We then conducted additional rounds to target in particular low and low income countries that poorly responded initially to the survey, probably because of COVID also. 746 hospitals were contacted in total. We aimed for a minimum of 4 hospitals for each of the 4 income levels as defined by the World Bank. Next slide, 69, showed you the early results of this survey, Global Sentinel Survey. For those interested, you should access the ICPIC abstracts, and you will find the results in an abstract form. And you can see on the next slide, 70, the distribution of hospitals that participated. 51 hospitals from 35 countries completed the survey. And as you can see, we have countries from low income, lower middle income, upper middle income, and high income regions and countries all over the world. Next slide, slide number 71. What are the very first results of this Sentinel survey that we conducted? And what are the main conclusions? Well, let's start with the conclusion. Both lower and higher resource environments had major issues with their healthcare environmental hygiene programs. And this is very, very important to realize. We can all make progress, and progress can be made all over the world, the same way we found it for hand hygiene at the very beginning. Next slide is slide number 72. That simply showed you part of the framework. It's not for the purpose to be read. It's only part of it. It's for system change, but we have, of course, many elements included in this framework. The next slide, slide number 73, try to show you a few results, actually, of this survey. What cleaning products and supplies are available for surfaces in your institution? And here we showed you the data for healthcare institutions in higher income countries versus lower income countries, just to show you some comparisons. What about detergent? You see the difference, 70% versus 86. Bleach, chlorine-based disinfectant. Look at the difference, 74% versus 93%. Products that combines both a detergent and a disinfectant were much more frequent in higher income countries versus lower income. What about quaternary ammonium compound disinfectant? Look at the difference. What about the use of wipes, clothes for cleaning by hand? What about mop and bucket systems, bucketless mopping systems, 17% in higher income, 29% in lower income? What about the use of sponges, larger mechanical cleaning machines for cleaning floors, large surfaces, very rare in lower income countries, much more frequent in higher income countries? What about UV disinfection machines? 48% of hospitals in our survey in higher income did get those machines, 0%. No hospitals in our lower income sample. And what about gases, hydrogen peroxide disinfection machine, a third of the hospitals versus 0. Let's move to the next slide, slide number 74. What supplies are available for sterilization? Look at the differences. Equipment for the chemical sterilization of instruments, almost 83% versus almost 29%. Products for the chemical sterilization of instruments, 83 versus 36%. Equipment for the heat sterilization of instruments, 82 versus 100%. Product for the heat sterilization of instruments, 78% versus 43%, and so on and so on. And as you can see, sterilization is outsourced in 30% of the higher income hospitals in countries of higher income versus 0% in the lower income. And then adequate sterilization is not available in 4% in higher income countries versus 21% in lower income. Next slide. What supplies are evidence for water quality and control? Clean water, running water, additional water filtration when needed, 78% in higher income, 21% in lower income. Next slide. What supplies are available for air or air control? Windows that can be opened, ventilation system, HEPA filtration system when needed, 87% versus 21%, and so on and so on. Next slide. What supplies systems are available for waste management? Containers for sharp, 100% versus 93%. Separation of normal versus medical hazardous waste, 91 versus 71%. Machines that shred and sterilize, 26% versus 0%. Waste collection services, 96% versus 79%, and so on, and so on, and so on. As you can see, huge difference, and we need to work on those aspects that are extremely important in our field. Next slide. Does your hospital have different protocols for different risk zones? Offices versus patients' rooms versus operating theater, etc., etc. Well, healthcare environmental hygiene protocols do not vary from one zone to the next, 4% versus 14%. Some protocols are adapted to high-risk zones, such as operating theaters, transplant wards, 13% versus 57%. All healthcare environmental hygiene protocols are adapted to each risk zone, 83% versus 29%. So there is a large area for improvement, as you can see from these slides. Next slide, what types of training those environmental services staff receive. Classroom teaching, on-the-job teaching, e-learning, 26% versus 7% only. Manuals or others. And it's clear again that education can really be a very, very important project for environmental services staff all over the world. Next slide. Does your hospital provide or require formal training for environmental hygiene staff? No formal training, some formal training, comprehensive formal training, only 30% in higher income countries versus 7% in lower income countries. Next slide. How is your staff for cleaning members' performance monitored? No monitoring, 12%. Irregular visual monitoring, less than 4 times per year, 22%. Regular visual monitoring, more than 4 times per year or more, or regular visual monitoring as well as additional monitoring methods, 40% on average. Next slide. Is there on-site management of your staff, your cleaning staff or environmental staff? Never. Sometimes 45%, often numerous times per week, or always 23%. Again, a lot of progress can be made in this field. Next slide. Is there on-site management of EVS staff? As you can see here, these are the numbers and the proportion. As you can see, on-site management is actually zero, is always in 23% versus 14%, often 27 versus 29, and sometimes once or less per week, 50 versus 43%. Next slide. Do environmental services staff and nursing staff speak the same language? This question is very key. You know what? Because the nursing staff need to speak to the environmental services staff. It's obvious. But as you can see, it's not rare that they even don't speak the same language. And it's true in higher as well as in lower income countries. So there's a huge work we need to do so that those people will need to speak every day about cleaning the environment, who is doing in what, who has done what, who is doing what type of technique. These need to be improved. I was speaking at the beginning at silos between and fragmentations in this field of environmental services, environmental cleaning, and that's very, very important to understand. Next slide, slide number 85. How easily can EVS staff initiate communication with higher level of the hospital hierarchy in general? Well, you can see no upward communication with superior is possible, 9% versus 21. Upward communication with direct superior is possible, 41% versus 14%. Upward with direct superior is frequent, 23 versus 36. Upward communication with superior above direct management is possible, 14 versus actually 21%. And then upward communication with superiors above direct management is frequent, 14% only in higher income countries, and even less, 7% in lower income countries. Next slide, 86. Well, based on all these questions, I showed you, I hope, the large number of areas where we need to improve. Now, before that, we need to validate the healthcare environmental hygiene self-assessment framework. Testing the tool in at least 5 hospitals in our network in different geographic and resource levels, at Hygiene in Geneva, at the Hospital Center University of Bordeaux, at Imperial College in London, at Tashkent University in Istanbul, at the Hospital of Kuala Lumpur, and possibly other hospitals, and we are in this process. Then using in-depth feedback from colleagues in those hospitals and from stakeholders that participate into the Clean Hospitals Initiative to further improve and validate the tool to get it ready for the large-scale use is absolutely key. Let's move to the next slide, slide number 87. Slide number 87 is actually outlining my next item, the cost and value of investing in environmental hygiene, which to me is really something that is very important and that we need to address and we need to work on. Now, what about cost of value? I mean, it's easy to simply say that one small outbreak can cost over 1 million euros, dollars, francs, whatever, maybe 10 million pesos whatsoever. Look at this cost analysis of 7 outbreaks in an academic hospitals that you can access by Dick et al. Or look at the paper by John Otter and colleagues, counting the cost of an outbreak of carbapenemas producing antibacterial assay, an economic evaluation from a hospital perspective. You can access the paper very easily, and I will encourage you to do so. Next slide, slide number 89. How can hospitals save costs in environmental hygiene? Well, the first step is decide which elements need which level of cleaning. And that's why and where we need transposable models that can be adapted to any type of hospitals in the different resources, area and regions from all around the world, including my own hospitals, where we had to do these efforts many years ago. Now, calculate the cost and benefit of healthcare environmental hygiene in your institution is really important, and we will provide tools to do it quite soon as the model will have been developed. One of the key objectives would be to keep staff longer, to educate them, to motivate them, to make them proud of their work, and to make and facilitate the connections between the different silos in the hospital that make hospital environmental hygiene to look as an area that is not a priority for hospitals today. Decide also when fancy high-tech machinery is necessary or not. When is it that it saves time? And by saving time can save money. When is it, in the contrary, that it costs too much money and that you better have to invest on a different approach or a different cleaning technique? Next slide, slide number 90, to actually look at the perspectives for clean hospitals. Now, Clean Hospitals' current research agenda to finalize the healthcare environmental hygiene self-assessment framework in collaboration with stakeholders and partners is probably one of our high priority. To implement then this scoring system as a global worldwide survey on the medium and long term to monitor progresses and to make people access the tools that would be implemented following this measurement. Those tools need to be developed or fine-tuned and make those tools available to institutions to address the element of the healthcare environmental hygiene self-assessment framework that their institution needed supported in. And this is very key. Don't work in areas where it's not necessary to work, but work in area where it's necessary to invest. Developing and teaching modules for improving healthcare environment hygiene programs for high and low resource settings, for sure. Develop the type of trainers program that we develop for hand hygiene that are so successful today, and further develop the transposable model toward excellence in hospital environmental hygiene. Same way we did it for hand hygiene. We have hand hygiene excellence hospitals all over the world that teach other hospitals to become excellent. And that's very, very key. And then promote large, multi-site intervention studies to assess efficacy and cost effectiveness of intervention in the field of healthcare environmental hygiene. Next slide is slide number 92. The transposable model that I referred to aims to understand how the best healthcare environmental hygiene programs work around the world in different resource and cultural contexts. Aims to identify and develop universal themes to support and improve all over the world, to develop tools and resources for improving healthcare environmental hygiene in healthcare institutions based on so-called model hospitals, and development by clean hospitals stakeholders that are here to help promote the best techniques and then educate in order to implement those best techniques. Test the transposable model and validate it in different healthcare settings. Develop criteria for excellence in healthcare environmental hygiene. And as I said earlier, organize train-the-trainers program at healthcare environmental hygiene excellence centers so that the same snowball effect that we have seen for clean hands could happen for clean hospitals. Next slide is slide number 93 and is my conclusion slide. Healthcare environmental hygiene is a domain that deserves recognition considering its central role in patient safety. It is a multidisciplinary discipline that contains several elements. Its promotion should be based on evidence and should be multimodal. Clean Hospitals has been developed on the model of the Clean Hands Initiative, currently endorsed on more than 190 countries worldwide. Based on the most recently conducted evidence-based systematic review on healthcare environmental hygiene interventions to reduce environmental bioburden, patient colonization, and infections, successful interventions could be designed but should be tested more appropriately. The pilot-tested healthcare environmental hygiene self-evaluation framework is under further development, engaging a large group of stakeholders and institutions worldwide. A transposable model for healthcare environmental hygiene will allow in the future to engage all healthcare facilities worldwide. The cost efficacy or cost benefit of healthcare environmental hygiene remains to be tested in a larger scale and should be part of appropriate research in the near future. Next slide, slide number 94, is to thank very warmly our Clean Hospital partners. Here are the partners of this beautiful program that we are starting. We are opening the program to whoever is interested to join our program. This is, to me, what will transform healthcare environmental hygiene all over the place, all over the world, and I'm looking forward to the future of this project. Next slide. For those interested and for more information about joining our project, initiatives, or digital days, please visit the Clean Hospital website. You see www.cleanhospitals.com, and I would be looking forward to see and discuss with you these Clean Hospitals initiative in the near future. With this, I would like to thank you for your attention and moving to the next slides and turning back to Martin.
Thank you so much, Didier. I have to say, looking at the results of the self-assessment framework, I feel quite humble, to be honest, because although things are far from perfect in the richer nations, there are huge amounts of work to be done in low-income countries. And interestingly, when you presented your systematic review, the evidence review, virtually all of the studies, the good RCTs, have come since 2017, apart from the Wilcox one. And they are all bundle studies, which shows that you cannot just change a product and expect to make a difference or just implement training. You have to really adopt a multimodal strategy to improving environmental hygiene if you genuinely want to demonstrate a reduction in infection rate. And so given that there are so many opportunities for improvement, given the self-assessment framework, do you think, how could we go about prioritizing the key areas for improvement if a hospital makes an assessment and then decides we want to do something? Where can we go to get the biggest effect of an intervention before we start rolling through others?
Yeah, it's an excellent question, excellent remark, Martin. You're absolutely right. Multimodal intervention, as in many fields in infection control, proved to be the way to go. We will have to actually redesign some of the multimodal intervention to make sure that we actually have the basics that could be implemented as a universal approach. But definitively, multimodal approach is to be recommended. We need to work on the elements, on the human factors, on the critical other factors, mechanics, and so on. And it's very, very clear that there is a long way to go, but there is improvement to be made all over the world, which is obvious based on this survey and based on what we have. And I'm looking forward to more analysis of this survey. I just presented it to you, very preliminary data, because still the analysis is not complete yet.
Yes, it's really quite exciting. Anyway, thank you so much, Didier. We're at the end of our hour. Ladies and gentlemen, can you just have a look at this final slide looking at the upcoming talks on the Weber Training website? The 28th of October, we've got Hand Hygiene Reloaded with Professor Hugo Sachs. Always a pleasure to listen to Hugo. Going into November, we'll be looking at transforming the inner ICP educator, exploring core elements of an innovative professional's experience, the sanitation economy and public health, and emerging fungal infections. So some excellent sessions coming up over the next couple of months. Can I again thank Professor Pite for, this has been his, I think, 28th teleclass, so a key supporter of teleclass education, but also our patron sponsors, who are Diversi, Flyrox Technologies, Gamma Healthcare, Purell Gojo, and the World Health Organization, without whose support the teleclass series would not be possible. And of course, as ever, thanks very much to Paul for hosting this and setting it all up, because without him, where would we be? Anyway, I do hope you enjoy the rest of your day, wherever you are in the world, and I look forward to speaking to you again on a future teleclass. Thank you very much.
Thank you very much. Thank you all. Bye-bye.